Welcome to my podcast. Today I'm going to talk about an important thing that any doctor should know about, especially if you are in emergency or the acute medical setting or even the clinical setting. So it's just a briefing about ECG. How can you read it in simple ways? As we all know, it's an important investigation that in many clinical situations should be done, especially if the patient presented with chest or abdominal pain or shortness of breath, breathlessness, syncope, pre-syncope, and even sometimes in headache. And it's routinely done in any patient who's more than 65 and will undergo an operation, especially if they have history of heart disease or systematic illness. As we all know, it's 12 lead ECG, and it's like a snapshot in time for what's going on. So it's basically a cardiac conduction that starts in the SA node, as we all know, and then it will spread quickly through the atria to cause the atrial contraction to produce B wave, which is called atrial depolarization. And then the conduction reach AV node and travel through the bundle of heads, which is the heart motorway electric system, to cause ventricular depolarization or contraction that we presented by QRS complex, and then the ventricle will reset to cause repolarization and thus yell T wave. So ECG in simple terms, it's a graph with X, which represents time, which is the paper speed of 25 millimeter per second, and the other line is Y, which is representing the voltage, which is millivolt per centimeter. So the longer the current takes, the wider the QRS, and similarly, the longer the voltage, the taller the QRS complex, like for instance in left ventricular hypertrophy. So when we need to read the ECG and interpret it, we need to know, is there an electric activity, which of course doesn't mean that there is presence of the cardiac output. And what's the heart rate? Is it within normal, or is it low, or is it high? And we need to know the rhythm, if it's regular or irregular, and if the QR is preceded by B wave equally, and what's the cardiac index axis, and if there is BR or QRS or QT interval, and if it's prolonged, and if there is any pathological, for instance, like abnormal waves or Q or ST or T wave abnormality. So in that concept, we need to know the basic rhythm, which includes sinus rhythm, sinus bradycardia, sinus tachycardia, sinus arrhythmia, atrial fibrillation, which is AF, which is denoted by irregularity, and B waves can be seen, and atrial flutter, and of course first and second and third heart block, and ventricular tachycardia, ventricular fibrillation. So with the practice and experience, you'll develop across the time how you can spot those changes and what might be the reason. So for instance, if to have a quick look about the sinus rhythm, if it's brady or tachy, it's usually normally between 2 hours, it's maximum like 3 big squares. If it's below or more, it's either brady or tachycardia. And the other thing, you need to have a quick look if it's preceded by B wave in each QRS. So in that condition, it's sinus rhythm. If it's not, then it's atrial fibrillation. And if it's very irregular and it's so like structure, it's atrial flutter. And of course, for the blocks, we know that if it's coinciding with the B and QRS, and what's the BR interval, and if it's successfully with each beat and B there is QRS, but just there is a lengthening until one of the beats dropped, or if it's just regularly not coinciding with each other, and it just run like erratically in a regular way. And of course, the ventricular tachycardia is denoted by the bizarre and the wider QRS. And fibrillation, it's more or less like the flutter wave, but in more pronounced situation. So that's just in brief. Of course, you need to know what might cause, for instance, the blocks, and what might lead, like in certain medication. We know that QT can elongate. So we need to know roughly those commonest one that's well known for this kind of thing. And just I thought to touch upon just brief about how to read the ECG, just in simple ways like ECG for the dummy. Thank you.